Should we maybe start? Yes, welcome everyone, and please take your seats. And I'm very warmly welcoming you to today's first keynote session. I'm Hanna Gylansten, and I'm part of the GCPCC group here in Gothenburg, and also leading this focus area that we have towards development, adaptation, and evaluation of person-centered care. So this is really in my topic, this session today. So I very much appreciate that. And I'm supposed to moderate this session and see how we can get this organized. And yes, welcome everyone. This morning, I'm delighted to present to you Professors Joanne Greenhalgh and Bradi Granger. And they will talk us through the use of PROMs, inpatient and person-centered care, and such care models related to financing and healthcare systems, really. And our structure for the session today is that we will first let them present their parts, and then after that we will have a sort of a discussion between us, and we'll see. I'm not sure if we will be able to have any comments and questions from the audience as well, but we'll see how that plays out and how we are with time. So first, I welcome Joanne Greenhalgh, and she is a professor of applied social research methodology at the School of Sociology and Social Policy, and a past president of the International Society for Quality of Life Research. Did I understand that right?
Yes, yes. Yes.
And you have an interdisciplinary academic background with psychology, public health, health service research, and have focused on routine collection of PROMs, so patient-reported outcomes measures to improve patient care. And you also had this realist evaluation session on the Monday, so maybe it was a Monday or Tuesday. Yeah,
Tuesday,
this week.
Yeah.
So maybe some of you were visiting that one as well. So very, very nice. And yeah, welcome. The floor is yours, and you have a clicker here.
Great.
Yeah.
Thank you very much.
Thank you.
Well, good morning, everybody. It's great to see so many people here at 8:30 on the last day of the conference after a disco. So well done for getting here. I think you pat yourselves on the back. And thank you very much for that lovely introduction. And thanks for inviting me. I'm delighted to be here. I've learned such a lot during this conference, and in many ways I'm kind of glad that my talk was towards the end, because I've been able to sort of learn so much from the conference and try and incorporate a little bit of that into my talk. So you'll see my talk's called Patient-Reported Outcome Measures, PROMs, and Person-Centered Care. And I think what I wanted to start with was this distinction between patient-centered care and person-centered care, and what is the difference. I've learned a lot about what the difference is during this conference. And during my reading, I came across this really interesting paper by Jakob Håkansson Eklund. And they found that on the surface, when they looked at all the reviews, that a lot of themes about what constitutes patient-centered and person-centered care was very similar. A lot of the papers talked about empathy, respect, engagement, relationship building, communication, shared decision-making, a holistic focus, an individual focus, and the coordination of care. But what they found was, beneath the surface, these actual models of care are enacted very differently. And I thought that was really interesting, and it kind of, in some ways, inspired the title of my talk. And I've kind of thought about this the whole way through, thinking about patient-reported outcome measures as well. And patient-centered care, they argue that the focus is much more about the sick role and seeing the patient and maintaining functioning, whereas person-centered care is much more about seeing the person as an individual and thinking about how that person can maintain a meaningful life. And this, in a way, I think you can see this to some extent in when you look at the wide number of different patient-reported outcome measures that are there, because they vary even in how they're defined, in how different people have defined what they are. in the kinds of things that they measure, and also in their format and structure. So I couldn't think of a good analogy, so I came up with a chameleon that sort of, you can tell it's a chameleon, but they change color. And I love this one because it's so bright and colorful. But in other words, there's so many different kinds of PROMs out there. And, that raises the question of how and why and in what way can they support person-centered or patient-centered care. So even if you look at some of the definitions of PROMs, you can see over the years, it's interesting, going back early on to talking about patient-reported outcome measures, I think PROMs didn't even really become a thing, probably until the sort of late 2000s. Before that, people just talked about measures of functional status or measures of quality of life, and this new term, patient-reported outcome measures, probably emerged towards the late 2000s, I would say. And you can see even in these definitions that people talk about the commonality is that, yes, they're questionnaires that people complete, but they measure all sorts of things. So here we have Dawson et al. Talking about functional status and well-being. We have Keith Meadows talking about measuring actual quality of life. Then we have NHS England, who some of you may know have instigated a routine collection of patient-reported outcome measures for people undergoing hip and knee surgery. And they define PROMs as measures of health status and health-related quality of life. And then we have, before that, the definition from the Federal Drug Agency, which I think had a big impact on what was measured and the kinds of PROMs that were being developed when they introduced the requirement for drugs to demonstrate an impact on patients and the outcomes that were important to them in the process of drug licensing. And they have a very, very broad definition, which is any aspect of the patient's health status. So PROMs are hugely varied. And so it's a really interesting question to think, how can they support patient or person-centered care? And to some extent what they do, and many people have, I suppose, questioned and observed this, that they seem to take rich individual personal experiences about people's life and try and measure it, and to some extent reduce it to a number of, sometimes one number, sometimes a number of numbers. And I think this was really important if you think about where they come from. So the reason, the initial sort of rationale for developing patient-reported outcome measures was trying to get a sense of population health and understanding the general health of the population, but also for use in clinical trials. So I think we had a situation where when drugs or new interventions were being developed, they were being evaluated according to biomedical indicators. And this didn't give any sense of how that intervention or how that drug was having an impact on patients themselves. So that was the original rationale for developing patient-reported outcome measures. And you can see it's really important in a trial, you need a number. So that's where that comes from. But I think now the focus has shifted more around not just using patient-reported outcome measures as measures of an outcome, but also seeing them as perhaps an intervention in themselves in terms of supporting patients and caregivers in the clinical setting. So when we think about what a PROMs intervention looks like, generally the patient or the person would complete the questionnaire either pen and paper, which is kind of old school, but meant that still happens, or on a tablet or a computer or a mobile phone before they go and see the clinician. The clinician then receives the patient's scores, either as a graph or a score. And the idea is that then the clinician can look at those scores before the consultation and, talk about those scores with the patient. I think the underlying rationale for this intervention was a sense that clinicians aren't always great at picking up some of the issues that patients want to talk about. And so the idea was if we give, talking about program theories for people who attended the Realist session on Tuesday morning, the program theory, the idea underlying this intervention is that it will help clinicians identify problems that patients want to talk about. So there have been a number of models and frameworks that have tried to say, okay, well, how might this intervention work? One of the first ones was Maria Santana and David Feeney's model of how using PROMs in clinical practice might support communication between clinicians and patients, support patient engagement, and this in turn will help patient management. We built on that model when we did a really synthesis of PROMs feedback in clinical practice and almost charted a flow diagram or a logic model, if you like, of how this intervention is supposed to work. And you can see that the idea is that the patient completes the PROM, this is fed back to the clinician reviews the feedback, and the clinician identifies problem, or it might enable the patient to raise those problems, the concerns are discussed, and actions are taken. And so what I've tried to do for this talk is think, okay, how does that idea, those frameworks, map on to ideas of person-centered care? So of course, I started to use the Gothenburg Center for Patient-Centered Care model and tried to think about how would we map those ideas, and will it support patient or person-centered care? So I guess here we can see the idea is that completing a PROM might help patients reflect on their own health. It might give them permission, a signal that the clinician or the clinical team are interested in their problems and what they have to say, that it might give them permission and enable clinicians to identify what's important to patients. So thinking about how it might elicit the patient narrative. So I think those are some of the ways that PROMs might do that. Then if we move over to thinking about shared decision and partnership building and working in partnership, how might PROMs support that? So here we're at the program theory level as well. We're thinking, how might it work? So the idea might be that it would initiate a discussion between the patient and their clinician about what's important, to consider treatment options, and to work together to formulate a treatment plan. And I think PROMs all can be helpful for documentation, because you can track then how patients change over time so that you can monitor the impact of treatment plans, and then the whole cycle works again. So for those of you who know a little bit about my background, I am also interested in the evidence. So I think it's great that we have, this is how it might work, but I think we also have to think about, does it actually work this way in practice? What's the evidence that this happens? And here, I think it's really, really difficult because for many of the trials that have looked at the impact of patient-reported outcome measures on care in terms of the feedback, one of the things that strikes me is that they haven't really measured many of the outcomes that would be an indicator of person-centered care. The things that they have focused on in terms of outcomes are communication, and this slide just shows you some of the systematic reviews that have looked at that. There's been many systematic reviews, so perhaps the most recent one is a collaboration with Chris Gibbons and a large team who synthesized all of the randomized control trials in lots of different settings, and found that PROMs feedback does improves communication, but I'll return to that. What do we mean by communication? It does enable clinicians to identify problems. There was some evidence it had a slight improvement on quality of life, but unclear in terms of whether it had an impact on functioning. And then when you look at the trials, the systematic reviews that have looked at in more clinical areas, distinct clinical areas, in mental health, there was a systematic review by Kendrick et al., and they found that there was no difference in the actual symptoms between the groups that received patient-reported outcome measures feedback and those that didn't. And in cancer care, it was much more mixed. 3 out of the 4 studies that were included that measured communication that were included in the review found that it improved communication, had a mixed impact on symptom management, and some improvement on quality of life. So, but one trial did show a significant improvement in survival, and I think that trial was really important. And what it showed that actually what it enabled clinicians to do was intervene earlier before the adverse side effects stopped people receiving chemotherapy, and this is what improves survival. So there's no doubt that it can have an impact, and those of you maybe who went to the Realist workshop will be going, yes, but for whom and in what circumstances does it work? And I think RCTs are really powerful in trying to understand effectiveness, but they don't tell you what happens in that black box. And to some extent, as I mentioned before, they haven't really measured the indicators of what we might consider to be person-centered care. Perhaps communication, yes, but what happens in that black box? So what I've tried to do And one of the things that we did in our realist synthesis as well, and I've kind of added to that for this presentation and gone back to the literature, which has actually been really fascinating. And there is some evidence, so if we think about those components of person-centered care, there is some evidence that, yes, completing a patient-reported outcome measure really does enable patients to reflect on their condition. Completing a patient-reported outcome measure is not a neutral act of just information gathering. It's kind of an intervention in itself. When patients complete those, it really helps them think about, well, what's going on for me? Oh my goodness, that's a really important issue. I didn't realize that. It does help them understand what's important to them. And there is some evidence to say that, it does help clinicians identify those problems. There's also some evidence to say that, yes, it does give patients, it signals to patients that the people are interested, that their clinical team are interested in what they have to say, and gives them permission to raise those issues. However, there's a really important context to this, and some of the qualitative studies that we looked at as part of our realist synthesis suggested that actually relationships are really important, that you might be able to complete a PROM, but actually you need to have a good relationship with your clinician in order to feel like you want to share that information. And these are just a couple of little quotes that really stuck out for me when we were looking at that literature. When we move over to shared decision-making, however, I think the situation is probably different. So if we go back to the model that I had, what we tend to find is that, yes, that it does improve communication, but this bit here in terms of concerns are discussed and action are taken, there's much less evidence to say that action is taken. So there's some sort of blockage happening between the concerns being discussed and something happening. So this is what we tried to think about and look into that. And of course, there are lots of qualitative studies that have interviewed patients and clinicians about what they think of PROMs and what their experience is. And often, clinicians are very positive. They do talk about, yes, this has been helpful, and it's helped me identify the patient. But then when you actually look at what happens in the consultation, and not many studies have really looked and observed the consultation, what you tend to find, and these were, to be fair, some studies from over 10 years ago that we looked at initially as part of our realist synthesis. What tends to happen in that black box of communication is that clinicians tended to focus on discussing symptoms rather than functional status and well-being. And there was a relationship between the severity of the symptom on the PROM and whether that was discussed. But there was no relationship between the severity of functional problems that the patient had and whether they were discussed. And there was a sense that clinicians, doctors, continued to discuss common side effects of chemotherapy. Of course, that's important, but irrespective of whether that showed up as being a problem on the PROM. And there's some evidence to suggest they tended to sometimes shut down discussions of fatigue as something to be expected. And in some senses, the doctor's agenda tended to predominate. So these were studies from a while ago. So I've looked at the literature again and to try and see, well, what's happening, in those studies that have looked at what's happening in the consultation. Very small study by, sorry, I can't read because I haven't got my glasses on. The first one, which was on vestibular, there's only, it's one setting. It's only four clinicians. But again, they also found that, yes, there was more discussion of patient outcomes, but there wasn't actually any difference. They actually tried to measure patient-centeredness of the consultations, both by patient report and by observations, and found that there wasn't any difference in this idea of patient-centeredness. And patients didn't think that the PROMs had enhanced the relationship. Similarly, in Caroline Majal's study of epilepsy, they found that the doctors thought that PROMs had shifted the power in the relationship in the consultation, but patients didn't always feel that way, and patients still felt that it was clinicians that decided on the topics. And then, why is this? What's going on? And I think there's also been some other studies that showed that actually doctors feel that their remit is actually treating the disease. And the issues raised by PROMs were not necessarily in their remit. They were maybe in the remit of another clinician. And nurses also felt the issues were important. They wanted to discuss them, but they didn't always have the time. And patients themselves were often unclear about whether the doctor should be discussing the things that were raised by PROMs or actually sorting out their condition. And I think all of them showed that relationships were important. Doctors and nurses felt that in some studies they already knew the patient because they managed to generate and have this relationship with the patient. And even when they used PROMs, there's a really interesting study that showed that actually where nurses found it useful was by sitting next to the patient while they were completing the PROM and talking to them about what the findings were and saying, why did you think of that? And so this makes me think about, there's something here about this relationship that's really important. And I really like these two studies. I'm not going to read out the quotes, but I wanted to put them there because I didn't want to misrepresent what the authors had said, and they say it so nicely. But I think these two studies are really interesting because what they say is there is a fundamental asymmetry in knowledge and power between doctors and patients. And just training clinicians in communication skills doesn't often address that. So you can train clinicians to say certain things in the consultation, but it doesn't actually change that fundamental asymmetry between patients and clinicians. And perhaps we need something more fundamental. Their example is communication skills training, but you could probably equally apply that to just giving the patient a PROM before they go to the surgery. And this more recent one by Dariusz Gazliński, he says, we need to see this in terms of epistemic injustice. And actually, to solve this problem, we need to support clinicians or have clinicians actually recognize this power asymmetry, but also to recognize that patients should have an equal role and their knowledge is equally important as their own knowledge. That's actually the fundamental issue of what's going on here. And sort of, just doing one single intervention is not going to address that. And this made me think about, actually, maybe what we really need to do is go back to the beginning and think about how we educate clinicians when they're learning to be a doctor or to be a nurse. What does it mean to be a nurse and to be a doctor? It doesn't necessarily mean having all the answers all of the time, and it doesn't necessarily mean, of course, you know a particular sort of knowledge, but also so does the patient. And how can we get clinicians and patients to meet each other in the middle? So I think, it also is important too, and one of the joys of coming to this conference is by seeing these models that actually go beyond, in some ways, just looking at the patient-doctor relationship and saying, actually, this is part of a much wider system. You're talking about context, which for those of you, again, who came to my session on Tuesday will know how close to my heart that is. But, that relationship operates within a context which is sometimes supportive or not of enacting patient or person-centered care. So those are the things we also need to think about in terms of providing the right structure and the right antecedents to do that, providing supporting those processes. So I think if we really want to support PROMs to support person-centered care, we also need to start thinking about all of those other things around that relationship in order to support PROMs actually having an impact. So really my final slide, and I hope you will recognize this 80s pop group. I guess the message is it ain't just what you do, it's also the way that you do it. So thank you for listening, everyone.
Thank you very much. That was very interesting. I listened carefully to what you say about these PROMs, I think. I'm going to think about those a lot more. And it will be fun to discuss it later again. And now I'm going to present Bradi Granger. And she's a professor at Duke University School of Nursing and the Duke Margolis Center for Health Policy and director of the Duke Health Center Nursing Research Program. And your research is focused on health system and health policy support, including health equity, health behaviors, and self-management, medication use, which, of course, I'm extra interested in.
About that.
And to strengthen and facilitate safe care transitions across settings of care, particularly in cardiovascular disease. And you have also extensive collaboration with University of Gothenburg, and also had a formal affiliation quite recently here.
Yeah.
So, welcome. The floor is yours.
Thank you. Thanks, Hannah. I think Joanne's right. It's impressive to see so many faces here this early morning after the disco. So thank you. We both thank you for being here. So when I spoke with Axel about this session, he asked me, how do you really define value-based care? So this kicked off our conversation about how can we have person-centered care in the context of a value-based system. And I'll talk about some definitions of that. But many of you might be familiar with the failure of the value-based care effort at Sahlgrenska here in Gothenburg a few years back. And a bunch of, just for those who aren't familiar, a bunch of American consultants came and tried to fix the system of care at Sahlgrenska. It was a huge failure, and they all went home with their tails between their legs. But we have this cycle all the time in the US because the US healthcare system is very driven by money. And so it's hard to get person-centered care to be the focus of conversation. So today I'll share with you a little bit of the shift in what's happening for us on value-based care, and I think it's in a positive direction. So how do you advance a person-centered care model in a value-based healthcare system? And there are, of course, a lot of models. I'm glad this is Thursday because we've now been saturated with all of the models. The World Health Organization, the BMC, the NIH, CMS has their own person-centered care model, the Flower. And at the end of the day, these models are all measured in some similar but also many different ways. And I think the simplest way is from Inger Ekman's work in making care primary, the three main things. How do you initiate the partnership and the narrative and the listening activities? Lots of ways to measure that. How do you work the partnership, co-creating a plan, developing shared goals? Lots of ways also to measure that. And then sustaining or safeguarding the partnership. Sustaining is a better word for us at home, but safeguarding or sustaining the partnership also can be measured in many ways. But measurement is critical, and so what we should measure has been a thread for this week, and many really good reviews. I've learned so much about a lot of good reviews on how it should be measured: observational, direct measurement, and then these three key things from the primacy of person-centered care still, I think, underlie all of the models we've learned about and heard about. And so many of the measures that we've talked about this week happen at the point of care, in the hospital or in the clinic or in some direct interaction with a clinician. And as Joanne talked about, I think with the PROMs, there is an important aspect to that relationship that happens when a person is completing a person-centered care instrument or establishing a goal or even this act of shared decision-making. It takes the interaction, the communication, and there is some unspecified aspect of relationship development that happens there. It happens better in person or at the point of care, and this is from the training program that we had in Bilbao several years ago as part of the Cost Cares initiative. These slides are from Gothenburg, but I think they're great because we document, we talk about the goal, we document, I specify activities to read it, and if it's documented, then it's easier to measure whether or not it happened. But the problem is when the patient leaves the interaction. So after the clinic, after the hospital, then what happens? Then the relationship with the clinician is no longer so proximal. It becomes very distal. And the amount of time the patient spends, this point has been made several times this week, the patient spends most of their time not with us as clinicians, but with family, with community. And so what happens then to the goal and the activities in which they engage to reach that goal? There isn't a reinforcement that's a naturally occurring reinforcement. And so the measurement of the sustaining or the safeguarding of those goals and activities in the relationship, I think it's challenging to keep up with them and to monitor and maintain. So person-centered care in the US, and Joanne talked a little bit about this, it's been heavily regulated by all of our different regulatory bodies. Joanne mentioned the FDA and how they a little bit ruined the PROMs thing. But for person-centered care, it's been much more under the domain of the CMS, the Center for Medicaid and Medicare Services, our payers. And so this is like a bad advertisement to me. When I first began working here with Inger, it was 2000. And at that time, the CMS, this same page on the website read patient-centered care. And we had a lot of conversation about it. And they had this big thing, we're putting patients first. And it was all about patient-centered care. Today, it reads person-centered care throughout the entire site, and also all the materials produced by the CMS are much more focused on the person and much more focused on the engagement and the expectations of what should come out of that engagement, which brings us back to the measurement issue. So they specify that the purpose of this part 2 of the CMS person-centered care for the US is to really enhance engagement with the patient and family. And so this third item is the most important, I think. The idea that's being espoused is now much more aligned with the way that we see person-centered care, I think, globally. And that is the meaningful, intentional application of person and family engagement principles to all the policies and programs addressing health and well-being. Well, it is pretty broad, but at least I feel like it's moving in a different direction than where it started, and things are looking up. Then comes in the value-based care. So back to Axel's question, what is value-based care? And it is all about the aspect of value that is finance. And so the financial reimbursement and payment for healthcare has been sort of the underlying essence of value-based care. And so it's hard to pay for person-centered care because person-centered care requires more time, which requires more money. And so there's been a headbutting of these two constructs. And these are the definitions from the CMS on the two things. Person-centered care must be, or is defined as, responsive to individuals and their goals and preferences. It should be in a system that supports good patient-provider communication, and persons receiving care and their providers should be making effective plans together. So this is the official definition now for person-centered care in the US, which is a vast improvement from the original one. But value-based care is still really talking about efficiency primarily as a quality measure and focusing on quality, but the definition of quality in a value-based care system begins with efficiency. And provider performance, that means how well do you perform, and the way that's measured, we'll talk about that. And lastly, the patient experience. And the patient experience, I think Joanne has covered that so well, but it's very much measured by PROMs and PRAMs. So this idea of the relationship between these terms, value-based care and person-centered care, this is from the framework. In a value-based system, healthcare clinicians deliver high-quality care using a person-centered approach. This differs from fee-for-service, where patients get their health care from multiple siloed specialists who focus on a specific health issue rather than the patient's comprehensive long-term needs. So I feel like that we're going in the right direction, and yet, as many people have pointed out, when the rubber hits the road, are we actually doing this? And so this is the key components of measurement for person-centered care that the CMS advocates for, and I think we would all agree with measuring these things. But in a review of the medical records in the Duke Health System, we looked at 10 years of data, and there were these are the numbers of records with evidence that the care was guided by the PRAM, for example, or informed by the patient's goals, preferences, and values. We couldn't find any evidence of that being documented. That was success measured by patient-reported outcomes. In oncology, we had some small evidence that the instruments were actually used during the interaction, but that was it. So there in the heart center where I am, in all of cardiovascular disease, we found not one case where there were evidence of patient-reported outcomes. And each one of these, the integrated and coordinated care across the system also didn't exist. And an AVS is an after-visit summary. We have EPIC as our, several others do as well, but we have the EPIC as our health record, and it's very difficult to find this. So there was never a case where the after-visit summary actually reached the primary care provider in less than 30 days. But the readmission rate often happens in less than 30 days. And so there was zero communication about the integration of care across settings. So the last one, relationships built on trust and commitment. We also, it's hard to find evidence of that. So the only thing that was happening consistently was this management of chronic and complex conditions. But that's what we do as our job. So that, to me, is not really a person-centered care effort. So we took these data from the record review and decided what is person-centered care in the context of our value-based healthcare system. And we developed a small pilot program and tried to do this in a different way. And so the program was called Closing the Gap on health equities for people with severe hypertension. And we developed this person-centered model of care that really specifically was, in this case, was focused on equity. And just a second of background information. For us, there is a huge burden of hypertension. It's also global. I know the World Health Organization now has hypertension as one of its top 8 priorities, but we have almost 120 million people in the US with hypertension, and the majority of those are Black or African American. And this has been true for decades, and it has not improved or changed one bit. And it's also still true when you control for socioeconomic factors. So this portion of the population is disproportionately affected by this particular disease. And for me in North Carolina, it is especially important, and in Durham. So we are in the southeast where you see all the dark red, and the prevalence of hypertension just in our city is over 1/3. And 50% of those people are identified as Black or African American. Many of them are not on the correct evidence-based algorithm for their medical management. And there is some, it's under debate, but some evidence that there's a different response in the Black population for many of the drugs that are on the guidelines. So the guidelines differ, and the correct guideline is not being applied effectively for the people for whom it's designed. The other problem is this is our Duke quality scorecard, back to the measures of quality. These red boxes are the Duke primary care clinics, and if you're red, you're not meeting, blood pressure is not in control at the target goal. So this is a snapshot. I didn't list the names of the clinics there, but each row represents the quarters of one of the primary care clinics, and no one is doing a good job helping their patients control blood pressure. The only ones that are green are the concierge clinics and concierge medicine, where the physician has 1 hour for the visit instead of 10 minutes. So our aims for this project were to improve blood pressure, but also to improve the various processes and outcomes associated with that, including the patient-clinician engagement in this person-centered care approach. We were attempting to really live out PCC in the context of our value-based system. The third aim was all about identifying health-related social needs. So I'll quickly share the intervention, which was an outreach call to the patient and giving the patient a blood pressure cuff, a regular old Omron blood pressure cuff. Nothing Bluetooth, nothing connected, just a cuff that they could use to self-monitor. And then there was a visit. The patients are taught and discussed and learn about the role of hypertension, but they also learn about life skills, and they also learn specifically how to engage in communication with the provider team in the health system, but also in their community resources through the portal. The last piece of this, the call, the cuff, and then the connection is with the community and the resources in their own area. And so patients in this project were asked to map with us the resources in their own area that they felt could be helpful for them. And so this is a map of Durham County, and the patients then listed all of the things that were proximal to them, helpful to them, in any way they felt. What were the community resources that were meaningful or helpful for you? The patients mapped those, and then we set up partnerships with those community organizations to help them understand their role in the patient's attentiveness to the goal setting and in their support of the activities. This is just a very small pilot that we did, but we enrolled 330 patients, and we measured some process measures to try and attempt to get at the actual goal-setting process that occurred. And the blood pressure, our primary outcome, was reduced at the end of this short period by 10 millimeters mercury, the median reduction. And I put this small box in the top corner to share that 10 millimeters of mercury reduction is associated with a 27% reduction in stroke rate. And so if you think back to the map of the red stroke belt is where we are referred to, the stroke belt. If you think about that, 10 millimeters sounds like a small amount, but actually it's associated with a 27% relative risk reduction in stroke, which is a really meaningful difference clinically. And so lastly, with this project, we asked patients, what is your story? And this is, again, at the end of this small pilot, these are the things they wanted to express that they appreciated the most. The time spent talking, and these talks happened in the county, in the public library. So again, this is not in the healthcare setting, this is after. They appreciated being with people in similar situations as themselves, sharing stories. They trusted the group leaders. They had a sense of belonging. They were motivated to implement strategies that they hadn't thought of before, and they felt less lonely and less isolated. And so the social capital was something that we were really measuring and something that we tried to assess along the way, and we were pleased with the results at the end. But we're stuck then in the value-based care system. You have to scale something, and you have to scale it beyond your health system. So in our state, the entire state is of course in the stroke belt, but during COVID we had the benefit of expanding Medicaid, which is payment for those in low socioeconomic groups. And so there was a data connectivity system set up that connected the data system from Epic to the clinic and to the community. And it was called NC Care 360, North Carolina Care 360, meaning that the data capture involved from Epic in the health system to the clinic. It also involved the community. So through the portal, the patient portal, and this is a picture of our portal, that connected patients to these three ecosystems to which prior to this, the data had not been able to be captured. So we have the health system, ecosystem of data. Patients can log in and log out. And then we had the clinics, which was also slightly connected, but not great. And now those are very well connected. But we had never yet connected the community ecosystem with our health system directly in a data on a server. So this platform, NC Care 360, was a way to have a resource repository and a referral platform. That's one thing. Then we engaged the Care Companion, which is it's an app, but it's a communication app that patients can use to respond back and forth. I think many people have similar kinds of Care Companion apps, but this is a diagram of exactly what happens. In the round ball, the patient enrolls in the program. They select that they agree to communicate and work through Care Companion for their blood pressure analysis, meds, and symptoms. And those things get reported in through the phone. But then, instead of just being the phone, they also go to the electronic health record, and they go to an AI analyst. So this is an aspect of AI that I think of as being good. The data from the phone is analyzed by the AI. The trend is analyzed. Then the nurse or the care team gets the information only if the care needs to be escalated based on the parameters that the patient and the clinician establish together. And so at the end, there's quite a lot of data coming in. Most of it is not entered by any person. They can just talk. And it is collected and interpreted in a way by the AI, but there's a health team behind it. And so this allowed us to identify a number of health-related social needs that patients didn't want to talk about directly. And this topic has come up also this week. I think it's been good, but these are the issues with housing, food, and medication cost that came out of having this Care Companion as part of our team, the AI aspect. And so combining the value-based care and the person-centered care goals begin to look a little bit better. I think we were able, we have to wait for 10 years to get another major chart review like we did before. But we have a good feeling that I think things will be different the next time, because in just this small 12 months of data, we're able to see that it's easy now to see the documentation and the flow of information of the care that is informed by the patient. The success is measured by the patient with the patient, because they are in the seat of power in terms of their reporting and their goal setting and their weekly activities with their community partner. And so I think I bring up again Carl Svedberg's hard work on this diagram, which many other sessions have talked about this week, but there are structural features in our health system environment that we have changed. And by changing the structure, we have been able to, I think and I hope, make the system better for patients and for the approach of patient-centered care. It's easier with these critical enablers in place. It's easier for the data to reflect the patient's voice and for the patient's voice to be more dominant and more central. So where do we go from here? I think now it's Thursday, so we can all go home or go to lunch. But I think we're only going up, and we should be able to transform the healthcare delivery system and marry our use of AI in a way that patients can trust and that we also, as the clinician team, can trust. Thank you.
Yeah, and maybe you won't want to join me here for a little bit of a talk about this. I'm not sure how to sit here. Maybe I should sit here. I don't know. Have you here? Thank you. That was very interesting.
Shall I sit?
So
here, then
so
we can-
nice. Yeah, I don't know how we sit here. Like that's all
Musical
right.
chairs.
I'll sit by you, Hannah.
Yeah, and you were both talking about like with the PROMs and with evaluation of patients overall. So I was actually thinking a lot while I heard you both about this thing that we have an issue here. We have something that we want to do for our care. So we have the care is using some different kind of measures, PROMs and others, during the planning of care and during the decision making. And then we have some things here that we can also see that patients can do for themselves, like their self-monitoring. And then we have something here that we do for research. And I would be interested to hear your thoughts on like how would this differ? I guess there are factors that would differ in what we want to measure depending on what our topic is or like what our goal is with the collection.
I think our goal is to understand better what it is that the patient wants out of their life, out of the healthcare system, and the measurement of that, I think, takes many different forms, and it seems to me that the measurement should be directed specifically for the purpose. And I think you made a great point of talking about the fact that sometimes purposes differ, and for research on the efficacy of a specific drug, that's a very different purpose than quality of life, I think, in everyday life. I don't think I answered your question, Hannah.
No, but
I think
that's
the
part of
purpose,
it, definitely.
I think the measurement should be aligned with the purpose.
Yeah, yeah.
And the purpose is not always the same. And I think that's okay.
Yeah, and I think what's happened with PROMs is that they've, to some extent, been repurposed. Some of them were designed for one purpose, to measure outcomes in trials, and some of them have been repurposed for supporting a conversation, and sometimes there's a tension between those, I think. I think there's also a difference in terms of whether PROMs are supposed to be acting as a dial, so a test result. So is it the score on the PROM that's actually the important thing in the clinical consultation, or are they supposed to be acting as tin openers? That they're a start to the conversation. And I think that's where they align better with person-centered care. If we see them more as a conversation opener, and that's something that we need to explore rather than, okay, yeah, it's just another test result, let's move on. Maybe sometimes that's useful, but I think if we're thinking about person-centered care, I think that's how we need to conceptualize them.
Yeah, well, absolutely. Yeah, but I'm thinking a lot about this, like, we are often talking about here in the research center that we need to kind of make larger scale studies. So we need to do studies on a more like regional level, maybe, or maybe national level. How do we do that? Like when we want to measure these kind of factors, so to say, and understand how did we actually change this first initiating the partnership? How did we do that on a regional level? Then we need to collect a lot of PROM data, I think, or PREM data. So yeah, there's factors in this, and I guess calling for some digital solutions here.
Yeah, I think that's where the digital solutions help, because in this example of our project, it's one thing to do it in a single site, and it's quite another thing to do it for the state. And yet, it is possible with the right tools in place. I feel like the initiation of the partnership, it's an individual relationship, and yet that happens every day in every clinical interaction. The thing that we don't do well is capture that, and I think with systems in place to capture that in a way that allows for some flexibility in the dynamics of the engagement, like the setting doesn't have to be in the clinic with when things are allowed to be more fluid in terms of where they take place and how they take place, and yet the data can still be captured. And I think, Google is doing this every day with all of us. And so it is interesting to me that we haven't been quicker at getting this for healthcare.
We should get our watches to do this,
Yeah.
self-evaluation of these things as well, right? Yeah, interesting.
I think probably, yeah, I mean, I would see it also as, I mean, it was interesting you said about, does it matter how it happens necessarily, and maybe what you're seeing it as adapting the intervention to the local context, to put my realist hat on.
Yeah.
That, there's some core elements of that intervention, but actually there's some flexibility to adapt it to the circumstances of different places in order to make it work. And I think that's an important element of scaling something up, that it's not going to work in the same way everywhere in the same way.
Correct. It's like the patients mapped their resources in Durham. So that was great for us, and we could use that map. But then the care companion allowed, and the AI honestly allowed for the state, that same exercise can happen anywhere. And I think that community resources for activities of person-centered care specific to whatever disease, that honestly can come from the phone. You use a resource or so once, and then you all of a sudden get all kinds of information about similar resources in your area that are like that. And it's helpful in some ways.
Interesting, yeah, absolutely. And I was also, of course, curious to hear about this, like in actually putting the value-based in there, and of course, and you had discussions before as well. And like, so if they are like thinking of person-centered care in relation to the value-based thinking, do they also, like, would you say that it's built in that you see person-centeredness as something that has the value, or is it like a condition behind, then we do the value-based within this person-centered framework or something? Have you considered that?
Well, ultimately, the value for us gets translated into dollars.
Yeah.
And so I think that it's not always comparable to the European system, which I find much better for healthcare. So the thing that I feel is progress being made is that at least now the definition includes to me the things that are actually important to the patient and to the clinician in terms of quality. Value is measured by quality metrics, and I think to the extent that we can improve some of those, like equity and person-centeredness, then we can make an argument for reimbursement or payment for the care delivered based on the higher quality.
Yeah. But it would be interesting to know, like, if we would do like a willingness to pay study, would it be like the outcomes that are valued only, or would it actually be something in I'm viewed in this way and I'm met in this way in the system? Is that also something that you put value to and actually would want to?
You would
want to have, like, in a way, in itself, not only what it can potentially
I think
give.
the fact that the patient experience is in the very first line of the definition of the value-based care, this is progress to me. So I just think that what we're trying to do now is generate some evidence to support the fact that this is really the central aspect of care and not just the secondary.
Yeah. And if we would think of the PROMs, I think this would be the last question because I'm out of time here, but we could talk all day. But if we would think of the PROMs, would you say that there is like some optimal PROMs that we should definitely keep an eye on when we have these studies going on and these projects?
That's a really good.
That's a tricky one.
I mean,
that's the last one.
There are so many. There are so many out there. I think maybe.
Or like, like dimensions or something? Like it would be all right
Well,
to...
people have tried to do that. They've tried to work with patients and caregivers and various stakeholders to define core outcome sets that we should use in terms of measuring quality. So there is that. But again, it's what works in one place doesn't necessarily work in another. So I don't know whether there's an optimal PROM, and I think part of the process of engaging stakeholders is, I think, enabling them to choose what works for them rather than sort of mandating that you should use this measure, because the evidence suggests that doesn't always work. So I think the involvement in the choice, if you're going to use it, that has to sort of be the most important thing, I think.
I, of course, have extra interest in these things. So very much thank you for being here.
Thank
this.
you,
And I
Hannah.
think we're out of time, but just a second. I've heard that I have something going on here. I think these two are the ones. Good. Now, I'd like to thank you both for
Thank you very
coming
much.
to
Thank
talk
you.
to us and
Thanks.
tell us about your interesting projects and research and knowledge. And then I would also like to thank all the audience for coming here, even if it's the morning after the party. And now I invite all to come and join our last set of parallel sessions, and later keynotes and some concluding remarks. So we still have some time to get some inspiration and interesting discussions going. So, thanks for today.
Thanks.
Thank you.